auditing process. So we're going to talk about that as we go through it. We just want to make sure that you're clear on that. So first we're going to start in slide 2. And this was a big issue, especially when it comes to audits. I'm already getting requests from a couple of the different Medicare carriers and the commercial plans saying we think that the cardiologists have lost their mind. So look at slide 2, and this is what we're talking about. So we know we had a new taxonomy code, C3, with Medicare, which this was a new specialty designation for interventional cardiology. Now, it's not that your physician isn't a subspecialist, okay? That's fine. It's just that can you charge a new patient visit with this new taxonomy code? And it is definitely controversial. A lot of the interventional cardiologists want to look at this as just like, I'm now special like the EP physicians. But the thing you have to take a look at is medical necessity, and that's always the bottom line when it comes to getting paid for an E&M service and if somebody would come back and audit you for this. So what we're talking about here, and I just wanted to quickly comment on this from an auditing perspective, is the fact that let's say that your patient had a heart cath, and that doctor who did the cath doesn't do interventions, so they transfer the patient but they knew that they needed a stent, so they transfer the patient to the interventional physician for a stent. Well, what Medicare and third-party payers are now seeing is that doctor says, well, since now that I have a new designated taxonomy code for interventional cardiology, I can bill a new E&M service. If the patient's being transferred specifically for the procedure, there wouldn't be an E&M service. There wouldn't be if it was EP, because if the patient was being transferred for a pacemaker insertion, where is the medical necessity to evaluate the patient if somebody already told you what to do? So you wouldn't meet the criteria, especially for an initial hospital that needs 3 out of 3, because of that medical decision-making. Somebody else made it. If they're transferring the patient to you because, let's say in this scenario, the physician can't determine if the disease is bad enough where they need to have an intervention, so a PCI, or if they need to just go to bypass with the cardiac surgeon, and now there has to be a discussion with that physician, that interventionalist, and the patient, and that, basically prompted a new E&M service, and obviously you would have a possibility of an E&M service there. But there has to be a reason. It cannot just be a transfer. So I'm going to kind of leave that there. We do talk about that when we get into more coding and for hospital on a different side, not the auditing part. But I just wanted to put that out there because that has become such a kind of a pain when it comes to what the payers are looking at from an auditing perspective. I think that actually caused more problems than it did any good. So now we're going to get into the inpatient first on slide 3, and initial hospital care codes, 99221 to 223. So this is to report the first hospital encounter with the patient by the admitting physician or the consulting physician if it's Medicare. So if you're the admitting physician, and again, these are per day visits, so not per visit, and it's per inpatient hospital stay. So if they're already in the hospital, the only time you could actually use this again would be if it's a Medicare consult. But if you are also a Medicare admit, then you would use the AI modifier, as you can see by that 5th bullet, because that means admit inpatient, and that identifies that principal physician of record. So now you're going to be the physician that can also discharge the patient. That was one thing that was kind of buried in the Medicare manual over the last couple of years, was can we bill for a discharge if the patient's transferred to us or for the consulting physician? And we see a lot of multiple discharges being billed. And the answer is no. If you are